Bismillah ar-Rahman ar-Rahim. We are starting online lectures and activity Tanta Obstetrics and Gynecology 22. The title is Leiomyoma. I am Dr. Hesham Borg, MD degree, Assistant Professor of Tanta University, Faculty of Medicine, and I am a member of European Society of Gynecological Endoscopy and consultant of OB-GYN. Our title is Management of Uterine Leiomyoma. The objectives of our lectures starting by recognize the etiology of uterine leiomyoma and outline the types and pathology of uterine leiomyoma and the diagnosis and uterine leiomyoma, including symptom and sign, and also outlines laboratory investigations and diagnostic study. And lastly, recognize the medical and surgical treatment for uterine leiomyoma, including hysteroscopic and laparoscopic management. Introductions. By definition, uterine leiomyoma are circumscribed benign tumor composed of muscles and fibrous connective tissue element. They are also referred to as a fibroid from the connective tissue or myoma from the muscle fibers or fibromyomata, and lastly, leiomyoma. They are present in 20% of white women and 50% of black women by 30 years of age. Leiomyoma are the most common uterine masses and the most common neoplastic found in the female pelvis. They are present in 20 to 40% of women of 35 years of age or older. They vary in diameters either from 1 millimeter more than and to more than 20 centimeters. Leiomyoma may be single, but may be multiple also. Up to 100 or more have been found in a single uterus. As regarding the etiology of the uterine leiomyoma, the etiology including either cytogenetic study suggesting that leiomyoma arise from the single neoplastic smooth muscle cells, monoclonal tumor resulting from somatic mutation. A variety of chromosomal abnormalities involving chromosomal number 6, number 7, number 12, and lastly number 14 has been identified, suggesting a genetic rules in the pathogenesis of these tumors. Disruption of high mobility group genes on chromosome number 12 appear to be contributed to the fibroid development, and so chromosomal 12 is the most important chromosome for determining the cause of the growth and increasing of the growth of the uterine myoma. Second cause of the etiology of the leiomyoma is a hormonal cause. Hormonal affects the growth of the leiomyoma, but doesn't appear to be causal mechanism. Evidence suggesting that estrogen is a prominent for the promoter for leiomyoma growth, hyperestrogenemia. The evidence of hyperestrogenemia for causing of leiomyoma. Firstly, the fibroid are rarely found before puberty and stop growing after menopause, and the new leiomyoma are rarely appear after menopause, and leiomyoma is often grows rapidly during pregnancy. And lastly, GnRH agonists create a hypoestrogenic environment that resulting in reduction in the size of the leiomyoma, and so this is the basis for preoperative preparation for operation for leiomyoma, or sometimes using as a hormonal therapy, and will be discussed in details in the treatment of the leiomyoma. The third factor, local and paracrine factor, may be caused also as a blood supply and proximity to the other tumor may accounting a varieties in the tumor volume and rate of growth. In addition, some peptide growth factors may play an etiological roles. Epidermal growth factor induce DNA synthesis in leiomyoma and myometrial cells. Estrogen may exert its effect through the epidermal growth factor, and recent study in animals have been shown that pifludione as an antifibrotic agent suppress leiomyoma growth by its potent inhibition of fibrogenic cytokines and transforming growth factors and epidermal growth factor. Types and pathology of the uterine leiomyoma. We have three types, either intramural myoma, and this is the most common type and usually may be integrated to the intraligamentary leiomyoma. Second type is submucous myoma, which may be pedunculated through the cervical os and making cervical myoma. And lastly, subserous myoma may be passes through the broad ligament and cause parasitic myoma. This lecture showing that we having also here prolapsed pedunculated myoma or interstitial cervical myoma or paracervical myoma in the broad ligament, or we have over here submucosal interstitial myoma or intramural myoma, and you have also here pedunculated intracavitary submucous myoma, and they have subserous or pedunculated subserous myoma. Genetic changes of our lecture including hyaline generation, cystic generation, necrosis, mucoid generation, regeneration, infection, calcifications, and sarcomatous changes or sarcomatous generation. The diagnosis of the leiomyoma consists of symptom, sign, and investigations. The symptom including abnormal menstrual bleeding. The most common characteristic association with myoma is the bleeding. The bleeding is typically hypermenorrhea, either excessive long menstrual period or excessive bleeding during the normal period. Frequently, myoma are associated with polyp and endometrial hyperplasia, which may produce abnormal bleeding pattern. Second symptoms is pain. The usually uncomplicated uterine myoma generally doesn't produce pain, and so the normal myoma has no pain. But acute pain may be associated with fibroid due to either first retorsion of pedunculated myoma, second due to infarction of progressing myoma, and third changing to regeneration within the myoma. So this is three causes for acute pain associated with leiomyoma. The third symptom is pressure. The myoma enlarging, usually causing a feeling of pelvic heaviness or pressure symptoms in surrounding, especially the bladder, and so causing urinary frequency, urinary retention, and lastly, unilateral hydronephrosis, which can be diagnostic by IVP or by investigation by ultrasonography on the pelvis. Fourthly, the infertility. Infertility may cause when a myoma interfere with normal tubal transport for the oocyte, for the ovum, or interfere with implantation for fertilized ovum. Large intramural myoma located in the corneal myoma usually leading to closing of interstitial tubal portion and interfere with the tubal transport of fertilized ova. Second cause, continuous bleeding may usually interfere with the normal implantation. And lastly, endometrium overlying the myoma provide poor surface for implantation. Increased incidence of abortion or premature labor in the patient with submucous myoma or intramural myoma usually may be the cause for seeking for the treatment of such a disease. Our sign Bio of Myoma, firstly, abdominal examination. We show that the myoma may be palpated as irregular nuclear tumor protruding against the anterior abdominal wall. They are firm in consistency, softening, and tenderness, suggesting that presence of edema, presence of sarcoma, presence of pregnancy, and lastly, presence of degenerative changes. And so usually the fibroid is firm and consistency, but if we are finding it is soft or tender, suggesting four causes, either presence of edema, presence of sarcoma and tumor, presence of pregnancy on top of the fibroid, and lastly, degenerative changes. Secondly, by pelvic examination, the most common finding is uterine enlargement. In the case of submucous myoma, uterine enlargement is usually symmetrical, but in subserous, uterine enlargement is asymmetrical and irregular in outlines, and the myoma can move freely from main uterine body, suggesting presence of adnexial extrapelvic myoma. In case of pedunculated submucous myoma, it may be protruded from the cervical canal, as we are showing before in the picture. Laboratory and diagnostic studies, we have firstly CBC. In the case of excessive vaginal bleeding with fibroid, usually showing degree of loss of adequate replacement, coagulation profile and bleeding times when the history suggesting bleeding diasis, and lastly endometrial biopsy in the patient with abnormal uterine bleeding and with risk of endometrial hyperplasia. Fourth, ultrasonography, usually accuracy accessed during uterine dimension, leiomyoma, location, interval of growth. And so we are using ultrasound for a lot of causes. Firstly, determine the uterine size. Secondly, the uterine number, uterine leiomyoma number, location of the myoma, either subserous, interstitial, or submucous, and the interval growth and the next year anatomy and pathology associated with leiomyoma. We have routine ultrasound. doesn't improve long-term outcome compared with the clinical assessment alone. Ultrasound may be used to detect hydrourethral and hydronephrosis in a marked uterine enlargement, especially for large subserous fibroid. Second type of ultrasound, we use sonohysterography in the case to identify the presence of pedunculated submucous leiomyoma and endometrial polyps. Fifth type of investigation, we have hysterosalpingography or hysteroscopy. They can be used to evaluate the endometrial cavity in the work of patients with uterine leiomyoma and infertility or repeated pregnancy loss. Our treatment. The treatment of the leiomyoma must be adapted in each patient. If the tumor is not excessively enlarged and there is no symptoms, and the treatment may be not be necessary. And so if the tumor is not excessively enlarged and the tumor there is no symptom, the treatment may be not be necessary. And so we have golden rules here. If there is no symptom, no treatment. If the patient has no symptom, you have to give her no treatment, because this is the golden rules of the treatment. The treatment decision are based on 4 items. First, based on symptoms of the leiomyoma, fertility status of the patient, uterine size, and lastly, rate of uterine growth. And also we have the golden rules: if there is no symptom, no treatment. The treatment consists of 3 types: either observational treatment or observational therapy, hormonal therapy, GnRH agonist, and lastly, surgical therapy or surgical treatment. Firstly, we are observational therapy. In absence of pain, absence of abnormal uterine bleeding, absence of pressure symptom, absence of large myoma, periodic examination are the sufficient management. And so this is the true if the patient is near menopause, at which the time the myoma will be atrophied. And so observational treatment usually starting from the patient nearby menopause, aged from 40, 42, 43, and will be menopause at 47, 50. And so we make this observational therapy for the patient with myoma, provided with has no any absence of pain, bleeding, discharge, large size of myoma. We starting observation treatment consists of bimanual examination for all the patients, should be done from 3 to 6 months to determine the uterine size, palpation of the uterosacral ligament for evidence of endometriosis, regular blood counting should be done due for hypermenorrhea with a fibroid, and lastly pelvic ultrasonography. And so observational therapy, we don't giving any treatment for the patient, just observational, make bimanual examination and ultrasonography examination. The second second item for the treatment is hormonal therapy. We're using gonadotropin releasing hormone agonist, long-acting gonadotropin agonist, which suppress gonadotropin secretion and create pseudomenopause, may be given subcutaneously on monthly basis for 6 months. 55% reduction in the size of the myoma. Myoma usually regrow after the GnRH therapy is discounted. Prolonged GnRH agonist therapy is recommended in young women because of possibility of osteoporosis. But we have to mention that using of this hormonal therapy looks like a magic, because the patient when taking this injection subcutaneously, all the symptoms come improving, and sometimes all symptoms may be disappear. And so sometimes the patient not come up to the doctor again and repeated by herself this hormonal treatment. And so we have to note that we have to make the patient to not to repeat the treatment by her own, because if we have excessive repeating more than 6 months, the patient will have a severe complication as regarding she may cause for her osteoporosis, and the osteoporosis may be make fracture neck and maybe this from the fat in place, and also maybe changing in the voice, her voice, and become male voice. And so it's important to follow up with the patient and preventing to increase the distance more than 6 months. Lastly is the surgical treatment. We have decision for surgery or indication for surgery, and either 8 indications like excessive bleeding, chronic pelvic pain, protrusion of pedunculated submucous myoma through the cervix, rapid growth of the myoma at any age, larger size of the myoma more than 12 weeks, infertility patient with myoma after evaluation of the treatment of the other cause, pressure symptom like hydronephrosis seen by ultrasonography or RVP, and when the reproductive process is complicated by reproductive pregnancy loss due to myoma. This is the eighth indication for surgical intervention. Surgical procedure, we have either three items, either myomectomy, hysterectomy, or uterine artery embolization. This is one of the pictures showing using electrocautery for removing of the fibroid and using also bipolar and monopolar electrocautery to make complete hemostasis during myomectomy. Hysteroscopic management, we using hysteroscope, either diagnostic first or operative. The operative hysteroscopy, we using a resectoscope and using a resectoscopic loop to remove the submucous myoma. And this is a picture showing this is the loop. This is the loop of the resectoscope, and this is the body of the submucous myoma removed. And here we have cutting and removing all the myoma, and this is a picture of the end of the removal of the myoma by resectoscope. Laparoscopic management, we have here, this is a diagnostic laparoscopy, and here we have using myoma screw through the myoma and removing the myoma, and here are using a small incision using a microsurgical technique. And here we are using suturing either intracorporeal or suturing outside is called extracorporeal knot for making closure for the uterine wall. And here we closing the last step of the serosa by using small needle microsurgical, and we applying microsurgical techniques through the laparoscopic surgery. Lastly, uterine embolization. We are using a special cannula through the femoral artery, not femoral vein, and the cannula passes through the common iliac and to the aorta, arch of aorta, and turn down to the contralateral side through the common iliac and through the uterine internal iliac, through the uterine vessel, and to supply here, as you see, this is the cannula and this is the caster inside it, and you have a polyvinyl particles passes through the uterine artery and to the collaterals to close the feeding vessels to the fibroid. This is the way to have to management by embolization. Thank you.